We done a video last year with a patient who was in our inpatient unit, and he was 90, and the first thing he said on it was that all old people want is your time, and that was the one thing he felt that palliative care service gave him.
Hello and welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Fergal Fox, and today we're speaking about palliative care. Now, this is not an area that I'm very familiar with, and it's outside our usual health and wellbeing work, but I'm really delighted to welcome two experts in the area to the podcast today to tell us all about it. So we have Jacinta Kelly, who's Director of Nursing in the Northwest Hospice in Sligo, and we have Dr. Fergal Toomey, Consultant in Palliative Medicine with Milford Hospice and UL Hospitals Group, and he also works as the Clinical Lead with the National Clinical Programme for Palliative Care. You're both very welcome to the podcast.
Thanks, Fergal.
Thank you very much.
So, Jacinta, can I come to you first? Can you tell us what we're talking about here, palliative care?
Absolutely. And before I do that, what I'm going to do is actually ask yourself just to think about one word that comes to mind when you think of palliative care and you think of hospice care. So just maybe take a second to do that.
So for me, I guess the first thing that's coming up for me, I thought palliative care was care of the dying. That's the term I thought I'd heard in the past, working in the health service. I never worked directly with staff in that area, so I don't have much of a knowledge of it now, to be honest. I'm telling you here, I'm coming at with a clean slate, relatively speaking, but that's the term I would use, care of the dying. Am I on the right track there?
And I appreciate your honesty and hold that thought, and I'm going to ask you again at the end. But maybe just to give a wee bit of background for people that mightn't understand palliative care, and I suppose this is just the heavy theory part, so just bear with me for the beginning. But the World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and treatment of pain and other problems, physical, psychosocial and spiritual. And what's really, really important in that definition, that's what we work by every single day of the week. But what's really important for healthcare professionals and general public to understand is that there's no age limit in that definition. So palliative care is available to people of all ages. And I'm 20 years working in palliative care. And the youngest person I looked after was 3 days old and the oldest was 103. So there's everything in that. Palliative care is not just for people who have cancer. So the definition does not say cancer only. But interestingly, some people still think that it's only available to those people. So obviously we look after people who have cancer to which there is no cure. So the rate of cancer would spread to other areas of their body. And we also look after people who have non-malignant conditions such as end-stage cardiac disease, respiratory disease, motor neuron disease, dementia, MS, frailty, or sometimes just general old age.
So it's not disease-specific or
not disease-specific,
no.
And it's not age-specific.
Yeah.
And they're not mentioned in the definition, which is really important for people to understand. And the third thing, which I suppose is the big message we really want to get out to people today as well, is the definition doesn't mention end of life, death or dying. And yes, that is part of what we do, but it's not all of what we do. And I think it's really important for people to understand that palliative care is now available much earlier in people's disease trajectories. So they're the three hit-home messages that I really want to emphasise with people today. And there's loads of different types of palliative care. So maybe I'll hand over to my colleague now who might go into them.
Fergal, how do you explain that? Obviously, Jacinta has got her pitch quite clear there. And I was interested in what she said in terms of using the WHO definition of psychosocial, spiritual. It's not just that physical health piece. It's much deeper than that.
Yeah, you're right, Fergal. I mean, I think palliative care, like any part of healthcare, is much more than just physical problems. I think palliative care, like a lot of other areas of healthcare, looks to see what's affecting a person and their family when they're ill, whether it's a physical problem, whether it's pain, whether they're nauseated, but also how it makes them feel, how it affects their ability to work, how it keeps them awake at night. And we very much also focus on the family around somebody and their carers. And I think if we focus only on physical problems, we miss most of what's actually causing the greatest distress to people. What we know is that palliative care spooks a lot of people. Thinking about palliative care spooks a lot of people. And I think, as Jacinta has outlined in the WHO definition, we are about looking after people with advanced illness. So if you have an advanced illness, that is a worrying time. But we know from the evidence that the earlier people who need palliative care intervention can access it, the better their outcomes can be, the better their quality of life can be, and the better their care will be. And palliative care, there's a policy that we may talk about a little bit more later, a National Adult Palliative Care Policy, which was launched in September of 2024. And that is to cover specialist palliative care, which is what Jacinta and I work in full time, but also to cover level 1, which is a palliative care approach, which I think is just really good healthcare that everyone should be providing to people with any illness. There's level 2, which is general palliative care, which is often what somebody might be provided to if they're looking after patients who have cancer, or a GP who are looking after a range of patients in the community who they've known probably from birth and will hopefully know until either the GP retires or the patient dies. And it's really about, as a population, but also as a healthcare population, the healthcare staff, healthcare workers, recognizing that actually this person might have a palliative care need. And then how do I go about assessing that and making sure that the person gets the right care for them, delivered by the right person in the right place and at the right time.
So can you tell me about your own services then? You're working in the Northwest Hospice, Jacinta. So can you tell me what's your day-to-day like there? I'd love to know that.
So I'm nursing manager, director of nursing over the hospital palliative care nurses. We've 3 arms to our service. So our hospital palliative care team would go into Sligo University Hospital and they would see any palliative care patients referred to us that are inpatients. And that could be from the top of the hospital, from ICU down to the bottom floor, down to ED. So wherever the patients are, again, any diagnosis, wherever the need is. The second part of our service is the inpatient unit in Sligo. We currently have a 7-bedded inpatient unit. We are under construction at the moment. I have to give the construction a new build, and we're going to have a new 12 single-bedded hospice unit opened later this year, which is a fantastic achievement for the Northwest. And we also have a community team. And the services nationally are very similar. So our community team covers Sligo, Leitrim, South Donegal and West Cavan. So they would come in every morning. They could have a huge range of patients. They have to prioritise patients every morning and decide where the nurses need to go within the community. In their own homes, in nursing homes, in community hospitals, in residential care facilities, for example, intellectual disability services, and patients of all ages, all diagnoses. And the lovely part of the service is that the patients can flow in between it. So if somebody's at home with the community palliative care team and they ended up admitted to the acute hospital, our team continue the story and the journey with them there. They may come across to our inpatient unit, they may go back home again. Patients are constantly moving within the service, but what's lovely is the service moves with them. So wherever they are, we remain with them. And the other thing I suppose that's important to point out as well is, oftentimes because palliative care has changed, we often get involved for a period of time in somebody's journey and we support maybe the consultant in the hospital or the GPs with patients' complex needs, but we might not stay involved. We could discharge them again.
If somebody is engaging with a health service for a particular condition and they're referred to palliative care like an additional support service, like a belt and braces.
Yeah, it's an advisory service.
Yeah,
we're an advisory service. And I suppose we complement and we support the specialists. So if you think of a consultant who specialises in dementia care, they're an expert in that field.
Yeah.
We're experts in palliative care. So when you bring those two together, it can only be for the patient's benefit. But we might need to be involved for a period of time, maybe to make some advanced care planning decisions. But we often step back again and discharge patients from the service, and they may come back again months or even years later. And patients are always very surprised when you discharge them from the service because that's not what they perceive and that's not what they expect. And also, I suppose the service has changed in that a lot of places now are doing primary care centre reviews. So the community teams or the medical teams are going in with GPs and public health nurses into the primary care centres and they're having outpatient clinics there. So again, that's a very new way of delivering palliative care. It's not all about just going out to patients' homes now and seeing them where they're living or bringing them into acute hospitals for outpatients. So it's changed a lot over the last couple of years. And
sounds like there's huge variety in it, Fergal.
There is this variety in patients and individuals and family members that require palliative care, and there's a variety in what they're needing. It's true to say that if you have an illness, such as an advanced progressive illness, and you need to be referred to palliative care, you'd rather not to have that illness. And I think for me, the key thing, though, is that if you need palliative care, and particularly if you need specialist palliative care in Ireland, palliative care delivery in Ireland is a good news story. We are constantly seen as being in the top 2-3 countries for providing palliative care internationally. More recently, funding for palliative care is almost 100% now. Our services in hospice services particularly have never been as well funded or as well staffed in that matter. In essence, I think with the policy that has been recently published behind us and making sure that that is implemented, the changes that Jacinta has mentioned need to continue. For me, probably the most dangerous phrase in any language is that we've always done it this way, and kind of make it my modus operandi at the minute to challenge people to say, okay, what are you going to do to change? And in palliative care, that means developing new inpatient hospice units in the country. Next up is in Cavan, but following that in the Midlands, in Tullamore and in Drogheda, so that everybody, anywhere you live in Ireland, can have access to the same services that Jacinta and her colleagues provide at North West Hospice, and I, for example, and my colleagues provide it at Milford Care Centre in Limerick.
I'm struck by the depth of the engagement you have to go into this sensitive area in palliative care. What takes you into this area? Like, what's inspired you to work in palliative care? Back to you, Jacinta.
I'm 20 years working in palliative care since last December, and I suppose when I went nurse training originally, I remember working as a student in Letterkenny, and I was on an acute medical ward, and there was a lady that was diagnosed with metastatic lung cancer. So she had lung cancer with disease to the rest of her body. And it was big news, really shocking at the time, very poor prognosis for her. And at the time, she was in an acute medical ward that was absolutely so busy. And she kind of got lost in it because obviously, people with high care needs required, a lot of nursing input. But this lady at the time happened to be up and mobile. And I remember walking into the ward, looking at her, and she was going around filling up jugs for some of the patients, and she was going out to the shop to get the newspaper and the 2 litres of 7-Up and different things for them. And I remember looking at her going, I want to go into an area where I can give you more time. And I think that's what we try to advocate in our service all of the time and across the country, is that, yes, of course, there's always going to be resource challenges and resource issues, but we do have more time to give patients and families than you would see in other specialties. And that's only right, because our staffing ratio is different. But that's the one thing that people need and people want. And we done a video last year with a patient who was in our inpatient unit, and he was 90. And the first thing he said on it was that all old people want is your time. And that was the one thing he felt that the palliative care service gave him. People sat down, pulled up a stool, they came down to his level. They chatted to him, not necessarily about his illness all the time, but they just give him time. And that's not just for older people. I think that's across the board. That's what we do well, is that we have the time to give people. And as Fergal alluded to, it's not just going in and doing the physical care. It's the psychosocial, the emotional, the spiritual. You can't do that when you're just walking past somebody at the end of the bed. You have to sit and come down to their level to be able to delve into that.
So it's about time, really, that personal engagement with a variety of different conditions and situations and age. Like you just said there, that's nearly scary to think about the broad span of age. I would have thought this is a very, very old clientele that you're working with all the time, but that's unfair.
And it's making it person-centred. It's not going in applying the same brush to every patient and every family. I work with a lady, and she used to always say that when you go in to visit a patient and family, you bring your palliative care bag with you. That has everything that we do as specialists, but not every patient and family will need everything out of that bag. So you have to go in and decide, where are they at now? What are they happy to discuss? What are they happy not to discuss? What do they need? We focus on quality of life. Is there things that's really important to them that we want to achieve? If somebody has a poor prognosis, we've brought weddings forward, we've brought communions forward. We've had all sorts of events that we are able to pull out of a bag within 24 hours. And that's with the great support of our community as well. It might be something simple like going to the beach and having an ice cream, or seeing pet donkeys, or it could be absolutely
so looking
anything.
at the bucket list and getting into it.
Yeah, and making sure that we can achieve those wishes for people. And, we mentioned how important families are to patients, but also what's important can be the four-legged friends or the pets or the animals. And that visit can be as important as family members coming in. That's the person-centred piece.
Yeah, it's really about human relations, isn't it?
Yeah, absolutely.
So you're working with the individuals, and you're obviously working with the families as well.
Yeah.
So what's that engagement like?
It's such an emotional time for everybody, because it depends how long somebody is diagnosed. It depends how sick somebody is. It depends what the prognosis is. But for a lot of families that might be diagnosed, with a metastatic cancer, that's a cancer with a secondary spread, that could just come like a bolt out of the blue. And for some families, within a couple of weeks, they're meeting us. And a month ago, life was normal, and they just feel like the rug is completely pulled from underneath them.
They could be in shock, or there could be at different stages of
Absolutely
getting the handle of the situation.
And you're trying to build that relationship with them. You're trying to support them as best you can, and you're trying to talk in a language that they understand, and not go in with jargon that they'll walk out of the room from you and they haven't a clue what you said. Like oftentimes when you'd visit patients or families, you write down advice that you might be given in relation to medicines, because sometimes as soon as you walk out of the home, it's gone.
Yeah, and once the stress goes up, the
Yeah.
retention goes down.
Yeah, absolutely. And they mightn't be sleeping right because they're worried and they're stressed. So, all of that can affect somebody's concentration. So it's really supporting them in that.
Yeah. Fergal, your experience of that family engagement, is there a process around that? Can you tell me a bit from your insights into that angle on it?
Yeah, I mean, it's very important. I mean, none of us exists, well, very few of us exist on our own. In fact, some do, but we're very influenced by those around us. And a key question I often ask people I come across is, I mean, what's most important to you today? Certainly, people of all ages, it usually is about their family, actually, those close to them. A young person with a young family is petrified of dying and missing out on confirmations and weddings that he or she would have wanted to be at. An older person is petrified of the fact that two of her children haven't spoken to each other for 20 years and she won't get it resolved before she dies. I think life is complex. Health is complex. Being sick is hard. And I mean, palliative care doesn't have all the answers either. But I think it's about sitting with somebody, being with them, maybe doing less speaking like I am now and actually listening a little bit more, because we're all experienced people. We meet lots of people in our work and our lives. And a lot of it is about actually just saying what's actually the most troublesome problem for you today and how can we manage it? I think it's true to say that when someone is told that they have an illness that they're not going to survive, so an incurable illness, an advanced illness, they never forget how that was done, what the situation was, what they were told. And like you and Jacinta mentioned a little while ago, most of the rest of the conversation after that news drops actually is they've no recall of it, they're not able to concentrate on it. I think what family members never forget is the care and the attention and the experience that the person they're close to, that they love, had around them when they died. We are all going to die. No one that I'm aware of yet has lived forever.
Isn't that the core here? We're afraid of the fundamental, that death is real for us all. You're smiling when you're saying that. None of us are going to live forever. But nobody addresses that until maybe we're looking at the gates or looking at, the serious.
I'm looking at one of my talks here as a cartoon I often use, but it's Charlie Brown and Snoopy sitting on a pontoon looking out at a lake and the big moon. So Charlie Brown says, "We only live once, Snoopy." And Snoopy goes, no. We only die once. We live every day. And in fact, when I meet people for the first time, I'll say, I want to make an impression that they'd like to come back and see me again if they needed to, try to make a connection. And I say, look, my job is to work alongside you, your family, the other doctors involved in your care, nurses, your GP at home, to have you as well as you can be, to feel as well as you can be, to live as well as you can for as long as you have, despite what's going on in the background, whether that's an advanced cancer, whether it's motor neuron disease, whether it's a person with bad lung disease. And as we heard earlier from Jacinta, an increasing number of the patients we look after in the community and the hospital setting don't have cancer at all. I think in the inpatient specialist palliative care units or hospice units, where more complex physical pains and symptoms like pain and so on need to be managed, we do tend to see more patients with cancer in that complex setting. But many people just want to be looked after where home is, where their family is, and that's what we try and deliver.
So in terms of taking on the caseload there, you said in terms of meeting families and meeting patients and wanting to engage them and encouraging, like one of your key messages today is engage early. How would you explain that, or what's the lifespan of an engagement in terms of, and maybe I shouldn't be using the word lifespan, but like what is the duration? Because it's just so varied.
It is. So there's no to strangers folk.
Yeah.
Another phrase, you'd never know what's going on behind someone's front door. And I think you just need to meet them at a level that allows people space to develop a rapport with you and give them the confidence that you and your colleagues know what they're doing and are there to help them. And I think also that if they don't need specialist palliative care at the minute, we say, look, love to meet you. We might meet you again. So I'm looking after a patient at the minute who's had a cancer diagnosis for 15, 16 years.
So when did they engage with palliative care?
Well, I discharged him from my clinic in September 2022, and I met him again last week.
Okay.
And prior to that, I was meeting him probably for about 6 months, 9 months. And prior to that, he hadn't needed specialist palliative care at all. It is really very, very varied. And we need, as a service, be able to recognize that if you refer to specialist palliative care, and in fact, your problems, your symptoms, your worries, your anxiety, the distress your young family member is having as a result of your illness is settled, well, then we'll discharge you from specialist palliative care. And that's a good thing.
So if the disease or the condition or the symptom has been managed well and the person is doing as well as they can, then that extra support system, the palliative care, is then? Are we getting near the definition now, isn't it, that support cloak or protective blanket that palliative care isn't needed? So you can take that off, and then when you need it, come back into it. That's what you're describing.
Yeah, exactly. Structurally, we have a national specialist palliative care referral form. We have criteria that make people eligible for that. But so much of the palliative care that's needed and so much of the palliative care that's delivered across Ireland is not delivered by people like myself and Ezine doing specialist palliative care all of our working week. It's provided by GPs, public health nurses, nurses in hospitals, hospital doctors. And where their pressures are and that time that Jacinta spoke about is so short, there's an increasing need for people to be able to take the pause and recognise that the patient in bed 5 or the person with heart failure in ward 4 actually has palliative care needs. And I think we need to be able to help people recognise that actually we need to make that space. We need to be determined that if somebody needs the care that Jacinta spoke about earlier on about that patient in Letterkenny, that somebody presses pause and has a think and says, okay, do I need to do what we'd like to promote people doing now? Do I need to do a palliative care needs assessment on this person? And name drop immediately anyone who's listening who's a healthcare provider. There's a very good e-learning module on HSE land for the palliative care needs assessment. For me, the first step to somebody getting palliative care that they need is someone in healthcare, the person themselves or their family recognising that, hold on a second, this person has an illness which might have them in a situation where they have a palliative care need. The next question then is, who can deliver it? Can I do it, or do I need to get some help?
Yeah, I like the way that you're putting that, can I do it? Because the way that I'm taking this off you there is that there's a broad church of support systems in the country, from a Joe Public point of view, supporting their own family member, to the public health nurse GP, and then up to the more tiered specialist. And absolutely, we signpost people to HC Land all the time. So what's the name of that course on HC Land?
So an e-learning module, it's called Palliative Care Needs Assessment. 45 minutes of your life that you'll be grateful for years to come.
That's good. So good. So that just guides people through the processes and the structure.
Yeah, exactly. Because we look at people's physical needs. We look at their psychological needs. Now, healthcare professionals do it, but formally in palliative care, we look at their physical needs, we look at their psychological needs and spiritual needs. We look at the social needs. What's the impact on work, on home, on their ability to collect their grandchild from school and so on. And all of these need to be looked at together rather than separately.
Yeah. And in terms of that policy that you mentioned, that policy was published last year, am I right?
Yeah, that's correct. September 2024, we launched at St. Francis Hospice in Blanchardstown in Dublin.
And what was the headline for you on that? I know that you're trying to create awareness of that at the moment, and you're trying to get people to engage early. Obviously, the resource on HSE land. But in terms of a policy, how is the HSE stepping up here with this policy?
Yeah, well, I'm part of a team working with Mara Stillen, who's the National Lead for Palliative Care in Access and Integration within the HSE, and other colleagues to develop an implementation plan, 2025-26 implementation plan. I think a policy is only as good as its implementation, and that actually, of the 104 activities that are outlined in it, that over the course of the next 5 to 7 years that these are implemented and put into place. As with Sláinte Care does come into it naturally, but the idea is that wherever you live in Ireland, whatever your illness is, whatever your age is, you will have access to palliative care. So universal palliative care. It needs to be available to people where they are. It needs to be of a high quality, delivered by people who are trained to work in palliative care, whether it's general palliative care, providing the palliative care approach, or specialist palliative care. And people need not to be financially at a loss or financially impacted by it. And we know that the need for healthcare and therefore the need for palliative care is increasing. So we know that by 2028, it struck me between the eyes when I read it, that we'll have more people over the age of 65 living in Ireland than under the age of 15. And that's only 3 years away. And that's a big change.
That aging demographic is coming down to us.
Exactly, it is. And I think we also know that in the next 20, 21 years that the number of people over 50 is going to go up by 50%. So from 1.4 to 2.2 million. So that's older people who are living better because of good healthcare, because of good health and well-being advice and self-care, I suppose, but also then will get more complex illness and more severe illness. And finally, I suppose evidence shows that for every one person who is dying with a palliative care need, there are 11 people living with a palliative care need. So by 2046, about 500,000 people in Ireland are estimated to have a palliative care need, whether that's a specialist palliative care need or a general palliative care need. And we might come back to our discussions about recognising death and dying
maybe we can go there next, because that's really where I was trying to go a few minutes ago in terms of our failure to acknowledge the sensitive part of life is death. And one of our earlier podcasts on planning for your healthcare future and making an advanced care directive and that kind of planning, we had this conversation about we don't like thinking about that. And that's fundamental to your raising awareness is something that people don't want to be engaged in.
Yeah.
So that death and dying, how do we use those words?
Yeah. So, I mean, culturally in Ireland, one of my colleagues would call it the nádúr. So we have a nature of caring and recognising the care of those who have died. We're very good at removals, condolence messages on RIP.ie, funerals, cups of tea, sandwiches, and you name it. And we are, I think, conversely, really quite poor about the acknowledging that none of us lives forever and actually thinking about and discussing with those close to us what matters most were I to become unwell. And there's an interesting study, which I don't have exact references for, but so the TILDA study, the longitudinal study in ageing in Ireland, there was a Northern Ireland equivalent acronym is NICOLA. But it showed recently that if you are an older person in Ireland, you're far more likely to have cancer treatment much closer to your death. You're far more likely, if you're in the Republic of Ireland, to have heart surgery if you need it close to the end of your life. And that's partly because healthcare is providing that care, but also because the population are demanding it. And I think there's discussions we need to have with people are, this is what your illness is, these are the options for your care, these are the options you'd recommend. And sometimes we fail to recognise when actually a treatment is available but isn't the best thing for us. And actually that it might not improve the quality of our living, it might not help us live longer. And for some people who have a very short-term goal, as in my daughter's getting married in 2 months' time, I'm desperate to walk her up the aisle. With that circumstance, you pull out all the stops where it's possible. But for somebody who's been in hospital for 4 of the last 9 months, who has been less well going home each time, and who recognises that they're deteriorating, it might be their son back from America or there's someone else who's pushing them to have treatment that in fact they don't maybe the heart of it want. And those are the kind of discussions that in healthcare we need to have about, look, these are all the options, these are the recommended options, these are the pros and cons. Let's be open about what's going to help and what we actually can provide.
Yeah, so you're encouraging people to have that conversation. What took you into this? You said to be telling us about being, inspired by that early insights or learning.
My experience is very similar to Jacinta's. I was working as a surgical intern in a busy hospital, and a team came along that gave people time. And particularly for me, the team I was working with couldn't spell pain management, let alone deliver it. And the specialist palliative care team that came along were giving advice to people, putting them at their ease and recommending to me as the intern at the time to prescribe medicines for pain relief. And that's what piqued my interest. And then as a trainee doctor, as an SHO, I got to work in the specialist palliative care unit and I was hooked.
Right. Because you saw that care or blanket that other healthcare professionals were too busy to see or to be able to provide.
Yeah, people talk about holistic care, and I think we overstate it a little bit, but it is about looking after all of the person. The specialist palliative care that Jacinta and I deliver, though, we continue to want this to develop. We continue to want to do research to find out how we can do better. And I think one of the challenges for us is to make sure that we, in delivering palliative care and specialist palliative care, I suppose, in Ireland, are actually proving that we are delivering high quality care. Slightly controversially, I sometimes feel in palliative care, we have pains in our backs and our hands from patting ourselves on the back. And I think we do good work. And it's important to be able to acknowledge somebody's gratitude for that work. But when it comes to working in this area, in the specialist field, when it comes to the state funding palliative care services, it's important that we can actually show that more than thank you cards, more than pats on the back,
results have been delivered.
Patients and their families are getting high quality outcomes, and that we drive that continuously. At the back of the care we're providing, the evidence and the governance are there to show it.
Yeah. From being so deep in the work, and I want to go to you, Jacinta, because you were telling me the other day about how you saw this service from the other side. Can you tell me a bit about that?
Yeah, and just before I do, I just want to do another shameless plug on the back of what Fergal had mentioned there in relation to the palliative care needs assessment. But I would appeal to any service managers, anybody listening, working in a general setting, to make the palliative care needs assessment module on HSE land mandatory for all of their staff. I think if there are any worries about these end-of-life care discussions, about, talking to patients about the holistic needs, about branching outside of the physical and talking about the social, spiritual, occupational domains. This is the module for them to do. So we're communicating with people across the health service every single day of the week. I would love to see this module mandatory to staff, but I think managers within their own local services can do that, and it's for all disciplines. So just to give that a shameless plug. But no, you're right, Fergal, I suppose. Like I said to you, I'm 20 years working in palliative care, but for 11 of those years I worked on the community palliative care team visiting patients at home. But back in 2011, when the community palliative care team visited a home, I was the person answering the door because they were there at the time to see my husband, Jason, and he had a brain tumour. He survived for 10 and a half months after his diagnosis. But, I suppose everything that we've talked about what palliative care is and the connotations and what people think and what people perceive, it just hit reality for me for when it came to my own door. And I meet families, I met patients. I thought I understood what it was like to be in the service. I thought I understood it. I thought I understood what families were going through. I didn't have a clue until I became that family member. And, and I have to acknowledge it was my colleagues that were calling to the door to visit.
That must be such a change of perspective for
Oh,
you.
massive.
Like, as well as going through the process of getting your head around it, dealing with it.
Yeah. Absolutely. Absolutely.
So sorry to hear that.
No, thank you. Thank you, Fergal. And, I suppose seeing them coming into the house and sitting at the kitchen table and going down to our bedroom because he wasn't well enough to get up that day to see them. And that's all that walk that I done in my job. And I remember sitting on the windowsill in our bedroom and I was looking at them on our bed talking to them. And I have no recollection what was said. I forget everything. That's what I said earlier on about writing things down. I have no recollection of that conversation because I just sat watching them thinking.
It must have been like an out-of-body experience.
Yeah, this cannot be real. This could not be happening. But, like with all families, they were absolutely amazing. And you can't underestimate the support of that car coming down the lane when that nurse is visiting. And I often describe it as they come into your home, they plug you in and they recharge you to keep going. Because as a family member, you're so tired, you're emotionally exhausted, you're physically exhausted. But I always felt when they came in and visited, they just plugged me into the wall. They told me I was doing a great job. They maybe made some tweaks to medicines if that was needed. They supported Jason as well. And they left the home and both of us always felt better after it. They would have known me very well, obviously. They didn't know him as well. But that's the other thing they do. They really, really got to know the person. They got to know him as a person. And that was really, really important, for us as well.
And how long was that in place for you?
They were involved probably for about 2 months before he died. So he passed away at home in our own house with their wonderful, wonderful support. And I suppose that's, another part of it too, is that sometimes family members you meet might be in the healthcare profession. So they're nurses, they're doctors, but they allowed me to do the most important job in the world. They allowed me to be his wife. I didn't want to be his nurse. I didn't want to be his palliative care nurse, certainly not. But I hadn't the head for it either.
Of course, yeah.
But they come into your space and they just allow you to just be the family member in it. And I remember one day ringing one of the home care team and I was really panicked and I was ringing to tell her that Jason had a high temperature. And there's not one person in the country who doesn't know what to do at a high temperature, but I didn't know what to do as a nurse. But that's where your head is at. And, she was so kind on the phone to me and not condescending at all. And she said, would you think about giving him 2 Panadol? And I was going, oh my God, I never thought about the Panadol.
So you really were living that other situation, that other point of view as a family member. She said it's incredible.
Absolutely. Yeah, absolutely. And, I suppose when I did go back to work afterwards.
Did you think about not going back to that area of work?
No, I suppose I always loved the work and it did cross my mind at the time. Will I go back to it? The main reasons I went back, number one was him. Jason had said to me not to use him as an excuse not to go back to work, which might seem like a little harsh, but he was right because he knew what the job meant to me. And then the other reason is those wonderful, kind, caring people that we talk about. I got to go back and work with them every day of the week and they minded me like a new penny when I went back. So there was never any doubt in my mind that I wouldn't go back to that area. And I have to say Northwest Hospice as an organisation were just fantastic to me as well while I was off, but also when I returned to work. And that support is really, really important. But when I did go back, it was with a totally different hat. Even now I look at patients, I look at families, it's different. I understand what a family is going through now. I understand the worry. Before Jason got sick, I would have went into homes and said to families, make sure and get a good night's sleep.
Yeah.
That's absolute rubbish. They will never get a good night's sleep, because when your loved one is sleeping, you're awake and you're worrying about them and you're wondering, did you forget anything, and have they had all their medicines, and how's tomorrow going to be, and will they have any pain, and have I updated everyone that I needed to update? Your head is racing the whole time. So afterwards I went into homes and I used to say, I don't expect you to get a good night's sleep, but will you try and get 3 and 4 hours? Because that's more realistic.
Yeah.
So I suppose it was different. Just looking at families afterwards was very different.
It's completely understandable. Thanks for sharing that. That's such a powerful example of taking the patient-centered approach from a service point of view. We've had a few podcasts on patient partnership, but to hear that example that you give it's so powerful. Fergal, give us some reflection of that. I don't know. It's very emotional.
I think you've used the right word, Fergal. It is extremely powerful and personal. I think befits Jacinta's generosity to share that with us. I did hear her make a presentation in which she spoke of Jason's illness and the care he received at a conference. And I don't think I've ever experienced pin drop silence for the duration of her words. We've had a brush or scare with healthcare in our family, and you get a fright enough with that, and everything is resolved, and happily everything is good. But I think Jacinta's experience is so powerful. And I think for me, hearing it, let alone for members of the public who are listening to the podcast, and again, particularly those members of the public who work in healthcare services, I need to bear what Jacinta said and the experiences she's shared with us in mind when I go around. And maybe that pause and that slow down, and that what you need as a healthcare professional is not to be a further drain on the energy and the psychological resources of someone. And I suppose that image that Jacinta gave of almost being in the sort of stepping outside the room on the windowsill, I think we need to remember that everyone is passing through life. They bring those closest to them with them. And in healthcare, we have a privilege to be able to dip in and out. And we need to make sure that what we do is really, really positive for those people.
Yeah, the term I love that you used there is the psychological weight that somebody is trying to deal with, their psychological baggage at that time. And if you're dealing with people that have family members or personally, they're coming to terms with issues around palliative care, that's a very heavy weight. And that makes sense then for the service that you're talking about. Provide a blank, provide the support, provide the space to have those conversations. Look at the social context that the person is living in. I can improve. Is there any element of their life that you can improve? And it sounds like that you've been doing that on a systematic basis for many years.
Yeah, and I think because people are different, because their needs are very different, I mean, we work with people who have complementary strengths and maybe make up for the absences and things that I'm not so good at. So I think when we meet as an interdisciplinary team each week, everybody genuinely has their take on what's going on for the patient, but is also giving their expertise in order that each one of the patient's needs across the domains of palliative care, the physical, the psychological, the spiritual and the social, are all given equal importance.
Okay. So, look, as we come towards the end of this podcast, there's been so much in it. I'm definitely learning a lot from you guys. I meant to mention the signposts in terms of your website. You're in Northwest.
We're in Northwest Hospice in Sligo. Again, just to give another shameless plug, there might be healthcare professionals listening who might be interested in getting more upskilled in palliative care, but also entering into the field of specialist palliative care. So I suppose as a first port of call, I would say go to the HSE's Palliative Care Clinical Care Programme website. Some really, really good resources on that, some national policies on it. So that's a really good first port of call. And also, make contact with your local hospices, because we're always in a recruitment crisis. So if there's people out there that is interested, let them know. Keep an eye on the HSE website as well in relation to jobs. But there might be people who want to do additional training, like certainly from a nursing point of view, there's higher diplomas in palliative care, there's masters in palliative care. They're run all over the country. We would have GPs that come on placement with us as part of their specialist training, and they spend time with the palliative care service. And obviously you can go in specialist into the medical field as well. So for all disciplines, if this is an area you want to go into and if there's a niggle there, do something about it. Scratch that itch.
And you're yourself an example of that. So you did.
I done with general nursing and then a higher diploma and a master's in palliative care. And then I suppose I still had this academic thing where I wanted to go back and do a wee bit more. So I'm doing PhD in palliative care at the moment. So I promised to drop the mic after that. I'm with the study. I'll just continue with my clinical.
But it's interesting to hear because, before we started recording, you were telling me you were engaging with the community teams where you had started working. So you're gathering information. That's where you're doing your research with. That's great to hear.
Yeah, I interviewed community palliative care clinical nurse specialists, and it was brilliant because I worked as one for 11 years, but you went into the role and you just done it every day and you didn't think about it. But I got to sit down with 9 wonderful experts and just talk to them about their job and what they do every day and what it means. So yeah, it's really, really good. My aim is to have it finished this year.
Yeah, it's funny when you say you sat down, you're taking your care-centered approach to your study that you've used in your work. Well done.
Yeah.
Well, the best of luck when you finish with that. So you're doing an open door there, welcome for people to get educated either on HSE land and that short course, or if people want to specialise in that area, that there's options out there in terms of the healthcare staff. In terms of what's coming up, we're doing this podcast to highlight palliative care and to promote awareness of it, but there's a palliative care week in September. What usually happens for that?
Well, our colleagues in the All-Ireland Institute for Hospice and Palliative Care, which is, as the name says, 32-county organisation, run the Palliative Care Week this year from the 7th to the 13th of September. And it's an opportunity to have a focus in the media a little bit, but also in presentations and meetings. Very importantly, getting the input of individuals who are receiving palliative care or families of those who are or have received palliative care. And there's often a launch, usually in the Mansion House in Dublin, of that. We'll be working with the All-Ireland Institute in the coming months on the meet that'll go into the Palliative Care Week for this year. For me, the key thing is that people recognise that none of us will live forever. People don't need to think about being ill, death and dying and bereavement every day of the week. But if someone close to you, or if you indeed yourself are unwell, don't be afraid to talk to people about what's worrying you. Your GP, your public health nurse, the nurse in the busy ward in the hospital who will make that bit of extra time to speak with you. And ask your healthcare professional, do they think that you need a formal palliative care needs assessment? And if you do, that's the key to receiving the care, general palliative care, the palliative care approach, or the specialist palliative care that you might need.
So look, we are getting to the end of this podcast. We could talk for hours. And I just want to ask, Fergal, was there any closing remarks or highlights you want to give?
It's very important that we listen to the public in Ireland who are receiving healthcare. And very importantly, the first National End of Life Survey in 2023 looked at the care that people received when they were ill and while they were dying in the health service. And the persons close to those people who died have told us that almost a quarter of them were unhappy with the coordination of care between the healthcare professionals and the health services that their loved one was receiving in the last 3 months of life. And that speaks to something that as a health service we need to improve, but in palliative care that we think we are good at for people who have palliative care needs, that coordinated care piece. But that overall care, for example, in the last 3 months of life, while being quite good in the hospice, there's always room for improvement. It was actually recorded at 46%, either good or very good in the hospital setting. Now we know the hospital setting is under terrible pressure, but there is something that can turn that dial in terms of recognising where a palliative care need exists. And yes, the referrals to specialist palliative care, community, hospital and hospice services have increased by over a quarter, over 27% in the last 5 years. But our policy is going to help us meet that need, providing general and specialist palliative care.
Okay. Thank you. Jacinta, closing thoughts from you?
I'm going to leave my closing thought to a patient, but just before I do, I might just go back to yourself, Fergal, just to ask, when you think of palliative care and hospice care now compared to the beginning of the podcast?
I think it's so broad. I didn't conceive the age span. I did think that, it was obviously a variety of conditions. I could see that. I never thought of somebody kind of coming in and coming out. I didn't really appreciate that kind of support system and psychosocial support that palliative care is. That's definitely kind of landed with me through your examples and through the discussion today.
Great. That's brilliant. Thank you for sharing. For any healthcare professionals listening, it's just, for me, the take-home message is that the palliative care is everybody's responsibility, not just the responsibility of hospice services. But I want to leave my last thought to a patient, because I suppose it's the reason any of us are in this area. It's the patients and the families that we meet. But years ago, I met a patient and I asked him, was he worried about the future? Because there might be patients, there might be families, or even just anybody that's listening. And I asked him, was he worried about the future? And without hesitation, he said no, because he said, if I worry about the future, I miss the present, and today I'm alive. I keep him in mind every day when I'm working or when I meet other patients and families. It's about for people to really appreciate the present, enjoy the present, and to make the most of each day, whether it's palliative care or not.
Yeah, that's beautiful. That reminds me of your cartoon, Varga. We only die once, but we live every day. Great. Thank you so much, Jacinta. So I just want to thank Jacinta Kelly, Director of Nurse at Northwest Hospice, Dr. Fergal Toomey, Consultant in Palliative Medicine and Clinical Lead for the National Clinical Care Programme Palliative Care. Thank you so much for coming in today. You really got under the bonnet on this and shared really deeply personal stuff and so much professional experience to give the listeners some valuable insight into this sensitive area. Thank you very much. To the listeners, I'd like to thank you for your continued support for the podcast. If you want to know more about the work of HSE Health and Wellbeing, you can follow us on X or on LinkedIn. Now we're on LinkedIn. And please share this podcast episode with somebody you think would get value from it. If you want to contact us by email, you can email healthandwellbeing.communications@hse.ie. And thank you for listening to another episode of the HSE Talking Health and Wellbeing podcast.